we'll go from there. All right, everybody. As you know, this was our big treat for the whole semester. We've been gearing up for this one, Grant, for a long time, because our program has no information on GLP-1s. And so we really get no information on how to use them, what they are, what the science is, how to use those maybe in a dietetics or nutrition practice, and what we might advise people who are taking them, or if we should advise people to take them. And those are kind of the things we're interested in hearing about, what they do with muscle mass, what they do with other things that I know you're interested in. And for the class, Dr. Tinsley is a good friend. He is a very well accomplished researcher and academic at Texas Tech University. And we've been communicating for, gosh, I don't know, 10 or 15 years at this point. We actually met at a conference years ago, the Texas ACSM, when I think Grant might have been a PhD last
Yeah.
year student, and I was presenting on something. Uh,
Yep.
but we met then, and it's been great ever since. And now I love to follow what Grant does. He's just an excellent person. So as I tell everybody, bring out your phones and make sure to give Grant Tinsley a follow, because he puts out great content in different spaces. So make sure you guys do that. Grant, if you don't see like at least 15 new followers in the next 10 minutes, tell me. We'll all take a point off our midterm exam. Sound good?
Okay, I'll do that. Yeah.
All right, so we'll let you get into it, Grant. We're recording now. Thanks so much for giving us your time. You have up to an hour and 10 minutes, but you don't have to use all of that. Just whatever you can get through today would be great. We'll ask some questions at the end.
Okay, yeah, fantastic. Thanks for the introduction. And as Dr. Ormsby mentioned, it's it goes back a long ways. My really admiration of him. So yeah, as a PhD student, he was definitely a faculty member I looked up to and was able to connect with, and followed for a long time. And he's provided some great mentorship and guidance along the way. He even came out here to West Texas on a lecture tour. So he got to work out in my home gym with me, which is how I know someone is, like truly a close friend. So,
That was a highlight.
anyways, what's that?
That was a highlight.
Yeah, no, that was great. So, anyways, yeah, it's a pleasure to be talking to you, and I'm going to give you a little bit about my background because it's not in medicine or pharmacy, anything related to that, but I have been pulled into a lot of GLP-1 work. But my background is likely more similar to some of you, though I'm sure you have some varied backgrounds in this room as well. So I kind of, present this as GLP-1 meds for exercise and nutrition professionals, but we'll just kind of walk through um, some of the points I think are essential to know, how I view this as a really exciting area for people in exercise and nutrition, not definitely not like a competitor to exercise and nutrition. So we'll go through all that. But just to give you a little bit of background about myself, again, to kind of reiterate that, some of the training may be similar to some of you. My undergraduate work was at Oklahoma State University, and I earned degrees in nutrition and physiology. I always had an interest in athletics. I played sports as a kid. I was actually homeschooled, so I did sports with a small private school, and we never had lifting. We didn't have any like strength and conditioning, nutrition, any of that. So, as a teenager, I was wanting to put on muscle and starting to see people, be more muscular, interested in all that kind of the fitness realm, getting probably very poor quality information from, fitness magazines and whatnot. But I had kind of this dual interest. I was a big nerd, loved science, was developing this interest in fitness, but didn't really have any guidance. And then when I was doing my undergraduate work, I was exposed to lots of people who knew a lot more about lifting, fitness, nutrition, and so on. And then additionally, I was studying that in the classroom. So after that period of growth at Oklahoma State, I did a master's in biomedical sciences at Colorado State University. And that, to be completely honest, it was a one-year master's program, and I was kind of buying time because I was not sure what I wanted to do yet. I wanted to get my CSCS. I was thinking about starting some type of entrepreneurial business in the realm of fitness. But I really loved the coursework. I got to do a lot of cadaver dissection, a lot of advanced physiology, and it really just showed me I wasn't done with school yet. So I was able to find a PhD program that, similar. As a side note, I talk about your department a lot because I really admire the combination of nutrition and exercise. And unfortunately, at many places, including my own university, there's separate nutrition and exercise related departments, even in separate colleges. So the synergy is not as high as it could be. But I found a PhD program at Baylor University in Texas that was a combination of kinesiology and exercise nutrition, which is really what I wanted to marry those two things. So I did the PhD program there. earned my CSCS as well. And honestly, still was thinking about doing something the entrepreneurial route of like having the, the credential of a PhD, but doing something more in the business coaching type realm. But during the PhD, I really fell in love with human subjects research. Up to that point, I had only done rodent research, which to me was not very interesting. I was dissecting rats, I was pipetting clear liquids into other clear liquids, pressing buttons on things, and it felt very disconnected from what I was interested in. But once I started doing human research, it really ignited a passion for the process of interacting with human participants, learning the technologies we can use to assess body composition, performance, metabolism, and so on. And then additionally, the writing, the data analysis, just all the components that go into research really were rewarding to me. So I ended up pursuing academia after that, and I got my first tenure track job after the PhD out here at Texas Tech. And I've been out here 9 years now, which is hard to believe. But so that's a little bit of background about me. And that, as you saw, none of that is in medicine or pharmaceutical sciences or anything of that nature. But the focus of my lab has really been body composition, sports nutrition, dietary supplementation, and so on. And really, I guess, the expertise in body composition, different assessment methods, just a critical examination of how we use these, how we validate these devices, what they're truly measuring. That expertise in the last few years has kind of pulled me into the GLP-1 area. And this maybe is more information than you want, but since I'm guest lecturing, I can just, do whatever, I guess. Uh,
Nope.
Dr. Ormsby will cut me off if he needs to. But it started through being on a podcast. If any of you are familiar with the physician Spencer Nadolsky, he has a large social media following, and he's a physician who specializes in obesity treatment. He's a former D1 wrestler, a gym bro, definitely like an exercise and nutrition type of guy. But he specializes in obesity treatment. And he and his brother, who's also a physician, had me on their podcast, and they were just wanting to dive into the details of DEXA and just the nitty gritty of what it is actually assessing, what it's not assessing, particularly in the context of weight loss and obesity. And this was around when some of the GLP-1 medications were getting approved for chronic weight management. And I'll mention that timeline in this presentation. But just from that conversation, we stayed in touch, and then he ultimately, I guess a year ago, officially started a business called Vineyard, which you'll see that logo on some of these slides because I borrowed a few of them from Vineyard. But he started this obesity management practice that largely specializes in the GLP-1 medications and cardiometabolic health, while also promoting a really strong lifestyle component. So there's access to strength coaches and dietitians who are all people who are highly active in promoting healthy lifestyles alongside the use of these medications. And so when he developed that business, I got pulled into that. So I'm serving as the chief science officer for Vineyard on the side, but my full-time position is still here at Texas Tech doing research. So point being, if there's just a small, like, broad life note there, the skills you develop in one area, you can potentially leverage into other areas and expand into other areas. So as you go through your education and career, I'd encourage you to think creatively about the skills you're developing. And if you are looking for a career shift, seeing how you can leverage those, or just being open to new opportunities that come along. Even if you don't immediately think that's your background, you may be able to develop the skills that you can, again, leverage into different areas. So I do want to cover a little bit of background just on what GLP-1 is, what some of these medications are, and then I want to walk you through just briefly a couple of the seminal studies for the main two GLP-1 receptor agonists. I want to show you a case series we just published about a few of our patients who had great success using these medications alongside intensive diet and exercise intervention, and then discuss a few other kind of more practical applications for people, I'll say broadly, in like fitness professionals, like nutrition and exercise professionals. And at the end, I'll leave some time for questions as well. Okay, so GLP-1 is glucagon-like peptide 1, and this is a gut hormone. So this is a hormone that's released from intestinal cells in response to eating. And it really produces what we call an incretin effect here. So this is a nice, very simple demonstration. What's being shown here on these two graphs, one is plasma glucose responses, the other is the insulin response. And you can see in purple, this is showing an IV glucose infusion. So just infusing glucose directly into the blood. The point being here that you're bypassing the gastrointestinal tract. And then in black, those dots are the oral glucose load. So what we traditionally do, obviously ingesting calories, nutrients through the oral route, it's going to go through the gastrointestinal tract, be absorbed, and so on. So you can see the plasma glucose responses when we're matching for the amount of glucose are nearly identical. But the insulin response on the right is very different. We get a much larger insulin response to an oral glucose load as compared to when we infuse. So what that means is there's something happening in the gastrointestinal tract that is enhancing this insulin response, which we know is very important for blood sugar management, metabolic health, and so on. So GLP-1 is one of these incretin hormones that is causing this effect. So if we look at this simple kind of old diagram, there'll be two diagrams like this. But if we look at food ingestion, again, this will activate certain cells within the small and large intestine, such as GLP-1 and also GIP, which is another hormone we'll mention briefly. I'll touch on this on the next slide, but these are broken down very rapidly, which is kind of part of the important rationale that led to these medications. But ultimately, these incretin hormones will exert their effect on the pancreas. They will have other effects as well. But ultimately, they will be facilitating a decrease in plasma glucose by increasing glucose uptake. And again, that's related to that insulin release, as well as decreasing secretion of glucagon to decrease that glucose production from the liver. Now, a potential issue here is this. Again, this is a very similar diagram, but there is an enzyme called DPP4 that very rapidly degrades GLP-1. So our endogenous GLP-1, the half-life is only about 1 to 2 minutes. So this is very rapidly degraded, meaning that its effects are not super long-lasting. And this also means that pharmaceutically, this could be a potential target if we have some molecule that could be exerting actions of GLP-1, which we'll talk about what those are beyond just the blood sugar in a second. But this was kind of a major factor that led to the development of some of these GLP-1 receptor agonists. So here I won't walk through all of this, but the main point here, again, if you look at the gut on this figure, is that we have GLP-1 that's released and enters circulation, and that will ultimately affect a number of targets. So targets in the brain are very important. This will be really critical to some of the effects we see with energy intake management and weight loss and fat loss with the GLP-1 medications. It's largely related to effects in the brain. We know there are effects on components of the gastrointestinal tract as well, which shouldn't be a huge surprise. If we have something released from the GI tract, it makes sense that it would be involved in feedback loops within the GI tract, again, to keep things in homeostasis within the body. But there are effects on GI tract, pancreas, adipose tissue. We're investigating whether or not there are direct effects on skeletal muscle or not. But again, some of the most important effects here are on the brain. Again, the natural GLP-1 is broken down so quickly that it doesn't have a long contact time with these receptors in the brain. And this is where some of the GLP-1 receptor agonists come in. So we'll look at some research for these, but two of the primary ones that you've potentially heard about are semaglutide and tirzepatide. And there are a number of brand names here too. So like Ozempic and Wegovy, for example, and then Zepbound and Mounjaro. Those would be some of the names. For those same drugs, it's just whether they're approved for like weight management or diabetes in terms of the specific name that's being used. But the point being, their half-life is more like 5 to 7 days. And these are GLP-1 receptor agonists. So they're going to be activating the GLP-1 receptors in various tissues, including the brain. But obviously much longer lasting. They are not degraded by DPP4. So they have enough structural similarity to activate the receptors without being broken down, though, by DPP4. And this relates to the dosing. If you're not familiar, the primary route currently, oral ingestion is being investigated, but the primary route currently is injection. So that injection is for both of these is once weekly injection is the recommended or the approved dose. So you can see how that relates somewhat to their half-life. So period where you're having reductions in circulating concentrations, that's where you would be kind of at your next dose. Okay, so again, there are other effects here, but it's really important and we'll circle back to this concept at the end, but nothing about the GLP-1 receptor agonist drugs is bypassing the things you know to be true about energy balance that you've likely had in a lot of class. It's just that these medications are very effective at modifying the energy intake side of the equation. There's limited evidence and not very convincing that they would modify the energy expenditure side, maybe a little bit, but it's definitely very well established, and you'll see from the data that there's a substantial reduction in energy intake, and that's really related to them promoting satiety, reducing hunger cravings. You maybe have heard the term, or maybe not, food noise, which has been kind of ambiguous up until recently when there have been some kind of defined constructs and even assessment methods for food noise. But many patients essentially report being able to like not think about food constantly while on these medications. So big picture, the brain effects we think are particularly important in the actual body composition and weight loss effects that we'll see. So these are truly they're truly a big deal. So I have the pleasure of working with Steve Heimsfield, who's an amazing researcher. I think he's published like over 600 peer-reviewed publications. He's 80 years old. He's incredible. He's still at it. He's still at the top of his game. He's a professor at Pennington Biomedical. He's been involved in this area forever. The point being that he thinks in his whole career there are like two paradigm shifts he's seen. One was the discovery of leptin and kind of our acknowledgement that adipose tissue, or realization that adipose tissue is not static, but it's a dynamic organ that is releasing components into the blood. And leptin was a big deal. It didn't pan out as dramatically as the GLP-1 drugs. But the second that he's seen in his, again, 60-year career is the like discovery and development of these GLP-1 medications. So there have been many headlines, pros and cons. Now we're kind of, how things go in the news cycle. There's been more on the, I would say, probably like fear mongering side effect side. But when these came out a few years ago, they were heralded as game changers, and they really are in clinical practice from what we've seen. Anyway, the approval for these medications for management of diabetes came a little bit earlier, but in terms of the approval for chronic weight management, this was in 2021 for semaglutide, in 2023 for tirzepatide. So I want to show you kind of the seminal studies, both published in the New England Journal of Medicine, just demonstrating the efficacy of these drugs. So this first one, again, published early 2021, before the FDA approval, was looking at semaglutide. It's you can appreciate, like anyone can appreciate how dramatic this graph is, but certainly, again, coming from the context of dietary interventions and supplements and interest in body composition, most interventions either were not effective or we're dealing with like really tiny magnitudes. It's like, can we squeak out like a little more fat loss? Can we get like a little more muscle gain or a little more weight loss or whatever it is? So you can see a graph like this, that this is, from hundreds of patients, and this is group level data where you see about 2% weight loss over 68 weeks in placebo and 15% weight loss on average, 15% on average in the semaglutide group. It's really dramatic. And again, this is driven from other research driven by the energy intake side of the equation. There are other ways they look at this, especially clinically, looking at the percentage of people who hit a certain percentage of weight loss. And this is really tied to some of the cardiometabolic and other health benefits associated with certain benchmarks. So I won't go into all the details here, but there's certain outcomes at 5% weight loss we'd expect to benefit, others at 10%, 15%, and so on. So if you look here, for example, at week 68, you're having 70% or so of the participants who achieved 10% weight loss, which is certainly clinically meaningful. Now, sorry, let me take a drink. From your program, you're certainly aware that weight loss is not everything. Not all weight is created equal. So we know, of course, body composition is very important. Both of these large trials I'm going to show you had a DEXA sub-study. So they had a subgroup of participants within the overall trial that had DEXA body composition performed. For this trial, I just showed you the step one trial. It was about 100 participants who were included in the DEXA subset. So here, it was shown that they lost about 7 kilograms of lean soft tissue, which, just as a reminder, you all may know this from your class, but for DEXA, lean soft tissue is just everything that is not molecular fat or bone mineral. So this is not directly the same as muscle mass. This would be all the water, the protein, the glycogen, and so on, everything that is not bone mineral and fat mass in the body, but still a relevant component, not something we want to see decreasing dramatically. So they saw 7 kilo loss in lean soft tissue alongside a 10 kilo loss in fat mass. So commonly, if we're trying to understand the composition of weight loss, we'll just look at the percentage as either lean soft tissue or fat-free mass. Fat-free mass would include bone mineral, while as lean soft tissue excludes it. But mathematically, it doesn't change the percentages dramatically. But here we saw about 40% of weight loss is lean soft tissue, which even without any context, you probably know that's not ideal. An oversimplification from prior research looking at non-pharmacological interventions, whether these were surgical interventions like bariatric surgery or lots of lifestyle interventions, we typically see in the absence of a structured exercise program that's geared at maintaining lean mass, we typically see on average 25% of weight loss coming from fat-free mass. And this is sometimes called the quarter fat-free mass rule. And this is an oversimplification. There are potentially some sex differences, certainly differences based on level of activity and so on. But nonetheless, this is a nice benchmark. So if we see something that's around 25% with a new modality of weight loss, we can say, okay, this seems about on par with other methods. We're not seeing a disproportionate lean mass loss. In this case, though, with semaglutide, seeing 40%, that is eyebrow raising, and that's not necessarily good. Again, this did not look at muscle function. It didn't even look at skeletal muscle volume, thickness, cross-sectional area specifically. But that was a potential concern. And this is where some of the concern about skeletal muscle loss came from, really from this DEXA sub-study. Now, the other major GLP-1 drug, and this is actually what's called a dual agonist. So this is a dual GLP-1 and GIP receptor agonist. If you remember, I mentioned GIP was another one of those incretin hormones, the gut hormones that are released in response to food intake. So this was tirzepatide once weekly, similar study to the semaglutide one, except they used different doses of tirzepatide. You see a very similar graph. So over here, 72 weeks, about 2.5% decrease in body weight with placebo, and then ranging from like 16 to 23%, depending on the dose of tirzepatide. So very effective. This was the SURMOUNT-1 trial, very effective for weight loss. Similarly, looking at the percentage of participants who met certain percentages of body weight reduction, if we take 10% again, we see at all doses, we're ranging from about 75 to 90% of participants who are meeting that 10% weight loss over 72 weeks. And I'll pause. I should have mentioned this before, but both for the semaglutide trial and this trial, participants in both the placebo group and the active group were given very generic lifestyle advice. Kind of like if you imagine someone gave you like a little paragraph about the ACSM recommendations, like, try for 150 minutes a week of X intensity, blah, blah, blah. They were given very simple guidance like that, but it was no supervised exercise, no intensive dietary counseling, anything of that nature. So very general advice. And as you saw, the placebo group lost a couple percent of weight. There's probably some component of them knowing they're being observed in the study, but maybe they were implementing some of these lifestyle strategies. But point being that there was not what we would view as nutrition and exercise professionals as an optimal nutrition or exercise program. Now, with that said, the DEXA sub-study for this SURMOUNT-1 trial with tirzepatide was quite a bit more favorable. So when you look at the loss of lean soft tissue and fat mass, the percent of weight loss as lean soft tissue comes out to about 26%. So right around that quarter fat-free mass rule that we use as just a rough approximation. So because of this, the current view is that tirzepatide, from the body composition outcomes, tirzepatide would be more favorable because it seems to lead to actually not only greater fat mass loss, but better lean mass preservation as well. Now, just a couple notes. People often wonder about the side effects, and the last bullet point here, muscle loss, again, arose from some of these trials in the DEXA sub-studies. And I'll talk a little bit about some of our individual patients and also kind of where trials are going here. But there are some side effects. I'm certainly not saying these medications are for everyone. I think the data is like very clear that group level people can benefit from these on the weight loss side. More anecdotally, it's really interesting working with Vineyard, the clinic, because we see many patients who are absolutely dedicated on lifestyle. I mean, ones who exercise 7 days a week, they're meticulous about everything they can be, and they still have a lot of trouble keeping weight off or maintaining a target weight. And many of them feel very freed by these medications, and they're seeing the success that they want, even though they've established these dietary patterns or these exercise patterns over time. They just haven't seen the benefits they want. So, with that said, they're certainly not for everyone. There are some GI related side effects. Nausea is a common one that seems to stabilize in a lot of people. But because there are effects on the GI tract, gastric emptying, and so on, some people could have reflux or constipation, other GI related effects. Fatigue can be a side effect, and some of that is due to the energy intake suppression. So, this is where ideally you want patients working with dietitians, which is what we do at Vineyard, because there is the chance that the energy intake is or the desire to eat is suppressed so much that individuals are not getting enough calories, macronutrients, micronutrients, and so on. So you do have to be very attentive to diet if someone is moving from a state potentially of overnutrition, and ensure they're not swinging completely to the other end of undernutrition in terms of nutrients themselves. And then muscle loss we'll talk about, but it is a great point for fitness professionals to come in. Now, I don't pretend to have like the full state of the I don't know, just the whole field on fitness and GLP-1s, but just being on social media, I've seen very different responses, kind of from the fitness, nutrition, exercise side of things. Some people are very pro. They're like, yeah, this is great. This helps my clients and so on. Some people really push back, and it's interesting. I think there might be some dissonance for some people who are like, oh, you just need to eat less, move more, all that. These medications are helping people eat less, so they're helping people address the core energy balance concepts. Again, these are not magic. They're not going outside the principles of thermodynamics. They're just very effective at helping people on the energy intake side when that needs to be reduced. But big picture, I would recommend anyone in the nutrition exercise field, even if you're not specifically working with these patients right now, just based on population level data, the occurrence of use of these medications is very high and increasing. They're definitely not going anywhere based on their effectiveness and some new versions that are being developed that I'll mention. But they're around. So I'm not saying you need to specialize in this area, but I'd recommend being open to this or open to patients who are on this. My view is that I'm all for tools that help people. This is a tool that help a lot of people who have the information. They know that they're not healthy, that their weight is a problem, that their clinical markers are not where they need to be. There are many people who have been helped by this, so their health has meaningfully improved. They've had resolution of lots of cardiometabolic conditions, obesity-related conditions. They've had those resolved. There are many people who are able to exercise a lot more. They achieve a body weight where they can do the exercise they want. So, I mean, we have patients who have over years gone from completely sedentary to doing like trail races and various fitness competitions and all kinds of things. And they ultimately achieve a body weight and body composition where they feel they're able to do that. And then honestly, I think this is a good tool as well, because I'm not sure how much you all have talked about this in courses, but as much as exercise is amazing for everything, it benefits every body system. It is not the most effective weight management strategy. And we tend to know this even in the fitness area. We know that nutrition is a big rock. Like if we're looking for weight loss or fat loss, nutrition really has to be aligned. Say for muscle gain, of course, the exercise stimulus has to be there. There are tons of other non-body composition benefits to exercise. But it's hard. Like if you're a fitness professional and a client is coming to you, presumably for weight loss or fat loss, it's hard for that burden to be on you. And say in the personal training context, you have someone, 45 minutes a few times a week, but you're not in control of everything they do outside of that. Even if you try to give them, say, like a meal plan or you're a dietitian and you're counseling them, it's hard to have that solely on you. So in some ways, I think this frees up fitness professionals. If you're working with a client who's on one of these medications, it's very likely that the energy intake management won't be as much of an issue, if an issue at all, as compared to the past. So I think what we see in many of the patients is they're very motivated to focus on muscle preservation. They want to become stronger. They want better function. We can look at all these great benefits of exercise that are not purely in the weight loss, fat loss realm, which again is not the strongest point of exercise participation. And again, there's no exercise injection. This is not replacing exercise. I don't think we'll ever truly get to this point. Like I mentioned, some of those randomized controlled trials without a good structured exercise program saw 25 to 40% of weight loss as lean soft tissue. We do have better studies ongoing with intentional exercise. Those have not been published yet in humans, but I do want to share just a few cases that we published recently as a case series. And these were just 3 patients. So this is a very small sample size, but we just reached out to patients who had historical records of all their clinical markers, DEXA data, and so on. So for context, the starting BMIs for these individuals range from 33 to 52. These were individuals who, what we said, just a simple summary here. There's details. This paper is published in open access if you want all the details. But they participated in these lean mass preservation practices. Essentially, they exercised or had some structured physical activity 4 to 7 days a week, including resistance training 3 to 5 days a week. The target protein, this is a little bit of a side note. Target protein, we normally do this in grams per kilogram, and that's great for lots of people. It's a little tricky in the obesity setting because you have some people with such high body masses that it's just not practically achievable for them to hit, 2 grams per kilogram. So we'll sometimes express the protein intake relative to fat-free mass instead, but their intakes range from about the RDA if you're basing on just body mass up to 1.7 grams per kilogram per day. But when we look relative to fat-free mass, this is more in the 1.6 to 2.3 grams per kilogram per day. So that's what they did in terms of their results. I'll show this a couple different ways. These were just 3 different cases, 2 females, 1 male. In black, you can see body mass, just absolute in kilograms. Blue, fat mass. This was from DEXA data. And then green, lean soft tissue. So generally, you see virtually flat lean soft tissue losses. 2 technically increased very slightly, 1 decreased slightly. But you see these parallel lines with the black and blue lines being parallel. We're essentially demonstrating that the vast majority of weight loss, or all of the weight loss in 2 of these cases, is coming from fat mass. You can see this probably a little bit better even on this graph. So here in the top row, we see the absolute changes in kilograms in these different DEXA components. In bottom is the percent, so the relative change. So case 1, for example, just wild. I mean, over 30% weight loss, over 50% fat loss. So this individual lost, over half of her baseline fat. This is the one who actually lost a small amount of lean soft tissue, but it was about 9% of her weight loss is lean soft tissue, as compared to like the 25% or the 40% we discussed. The other 2 cases actually had small increases in lean soft tissue alongside very large fat loss. So case 2 is incredible, like 60% fat mass loss from baseline fat mass, while completely maintaining and even just very slightly increasing lean soft tissue. Case 3, similarly, not quite as dramatic of weight loss, but able to experience a small increase in lean soft tissue. Just to show you visually, this is over 39 weeks, and this is actually someone who's taking semaglutide, which I said is the less favorable one for body composition. This is the one where on average we saw 40% of in the randomized large trial, 40% of weight loss is lean soft tissue. This was a case 2 in the graphs I just showed. So this is over only 39 weeks with essentially the worst of the 2 medications. And if you've looked at DEXA scans before, this should really longitudinally, this should really be amazing if you look from left to right on these scans. This is over only 39 weeks, so less than a year. You can see the fat in red. I mean, seemingly just melting off. And give all the credit to this person. She was exercising 7 days a week. She was lifting. She was trying to hit 10,000 steps. She was doing spin classes. She was doing like a high level of what we'd recommend on the on the exercise side. She was attentive to her diet, prioritizing protein and so on. And she was also taking this medication. But honestly, if I wasn't the one looking at these individual DEXA reports, I would not have believed this. And again, this is coming from the background of nutrition and exercise interventions and like what magnitude of weight loss, body composition change should we expect to see. So after years of doing that, then looking at scans like this, it's kind of crazy to see something that dramatic. Okay, so that was just a case series. We have a large prospective study going on right now with some of our patients all over the country where we're having them perform local DEXA testing, clinical markers, blood draws, all that. We also have a muscle performance component. It's just hand grip dynamometry because they're all over the place. So I've ordered, 100 of the same hand grip dynamometer and mailed them all over the country. And people are, performing their grip strength testing, doing a variety of questionnaires online about their participation in resistance exercise, other exercise, nutrition intake, and so on. But ultimately, moving kind of to some application in the fitness realm, I view this as a very positive thing. I don't view the medications at all as de-incentivizing people. Again, in the clinic, in our clinic, maybe biased towards people who are interested in the lifestyle component because we do promote that. But ultimately, we see people who are more motivated than ever. Like as their weight decreases, as their body composition improves, they're very motivated to get into all the nitty gritty of fitness stuff, and they feel freed up to focus on improving their function, improving what they can do, longevity. Um, you know, jumping into activities that they enjoy, but they haven't been able to do for a long time. So ultimately, I view this as a positive thing for the fitness industry. This is no surprise probably to anyone that's in the room, but we do think resistance training, that intense mechanical loading of the muscle, is our primary way to counteract muscle loss. Again, many of these trials, including ours, didn't look at, say, like MRI, skeletal muscle specifically. Those studies are coming, but using lean soft tissue as a proxy for now, we see better preservation with resistance training. And again, for fat loss, like if you're working with clients in this area or encountering people in this area, your job got a lot easier where you can focus on the amazing benefits of, exercise, training, and appropriate nutrition beyond just fat loss. And then I think a big picture point here is just to show empathy and compassion to individuals. And again, I came out of the, whatever, fitness magazines to studying nutrition, getting my CSCS. I came from the fitness side where, as a younger age, thought like, kind of everyone has the same 24 hours in the day and like work harder, like eat less, move more if you need to lose fat, all of that. And, there's some truth to those principles, but again, seeing patient after patient at the clinic who they know all those things, they're trying all those things, but it's really difficult for them. I think that the empathy and understanding that it's not the same for everyone. It's not as easy for everyone to get to their target physique or perform the way they want to. I think that's really important. And part of this comes down to understanding obesity. I'll show you one complicated graphic in a second just to demonstrate the point about the many factors that influence this disease. I think if you improve your understanding, if you are working with individuals in this area, improve your understanding, it can help you. Even if you're staying within your scope, you're not necessarily saying like, oh, you should go get on this medication. You should not get on this medication. But you understand more about, the physiology of obesity, the psychology of obesity, and these drugs. I think it'll just make you a more well-rounded fitness professional. Again, just it's a numbers game. At some point, you will be interacting with individuals using these drugs, or who knows, maybe athletes abusing the drugs. I don't know. We'll get into that. So again, just to reiterate, it is still about energy balance. Nothing about these medications is magical. But when we portray energy balance like this, like simple, just, oh, it's what you choose to eat, it's how much you choose to exercise, it doesn't take into account the complexities. Um, Part of this that's again really targeted by the GLP-1 medications is appetite dysregulation, and again the brain effects of the GLP-1s are what are particularly effective for helping individuals decrease their energy intake. This is actually outdated by a decade. They're updating this, which means it's just going to get more complex. But if we look at the circle in the middle, we're talking about energy storage. Obesity really is just defined as a state of excess adiposity, excess body fat. And we know that is related, of course, to energy balance concepts, thermodynamics, that all of that is true. So if you look, though, at these smaller purple circles around the large energy storage circle, you see different groups of factors that are contributing to increased intake or modifying intake and expenditure or decreasing energy expenditure. And what I like about this is, again, without even reading any of the words, just demonstrating the complexity of some of the factors here. The whole left side of this figure is showing factors inside the person. So whether that's physiological, psychological, or so on. But we know there are a lot of environmental factors as well, ranging for like tie-ins with food availability and socioeconomic status and whatnot, um, to environmental conditions, a whole host of factors. So the point is, energy balance is true. It's just way more complex than people realize. It's not just what you choose to put in your mouth and how many times you choose to go to the gym. There are many different things that consciously or subconsciously are affecting your intake and your expenditure, or your client's intake and expenditure. Okay. So if I were to summarize here, before we have, I think, a little bit of time for questions and answer. First, these are major medical breakthrough. This is not even if there are some components of a fad on the way certain things are sensationalized, overall, this is not a fad. This is a major breakthrough. These medications have been in development for decades before being widely available. This is a progressive scientific discovery. These medications, I think, came to the general awareness more within the last 5 years because of their approval, because of, whatever, notable celebrities who suddenly had lost a lot of weight, whatever it is. But they are a major medical breakthrough for overweight and obesity. They're definitely staying. There are new versions that are being developed, and I'm hoping maybe you've touched on some of these in other classes, because if so, you'll appreciate how interesting this is. But lots of targets that, say, in biochemical pathways that have been talked about forever in the fitness community as like holy grails of like magic muscle building, absent like anabolic steroids. Many of these pathways are now being investigated for combined pharmaceuticals that would have a GLP-1 receptor agonist in combination with some lean mass preserving agent. Which, as a side note, for sure, and nothing against people in the physique community. I have lots of friends there, love them, but for sure these are going to be abused in the physique community as soon as they're available, probably even in clinical trials. Like they'll find a way. But targets I'm talking about here, for example, myostatin. If you've seen the Belgian blue cattles or bully whippet, like the hypermuscular animals that have a myostatin mutation, that's what we're talking about here. So there's some drugs being tested that pair a myostatin inhibitor with this GLP-1 receptor agonist, and so far are showing more favorable body composition changes. There are versions being tested with SARMs too, so selective androgen reuptake modulators. And again, it's funny because a decade ago, these were, very hot and maybe still are in the fitness community and promoted as like a compound that could give you the benefits of anabolic steroids without the side effects. But now they're being studied pharmaceutically at a much higher level than like what the supplement industry was doing. Activin receptor type 2 inhibitors, kind of in the same realm as myostatin, of inhibiting some of these catabolic pathways within muscles. So, point being, in the body comp realm, it's going to be super interesting. In addition to like the decreasing energy intake and the associated fat loss, we're now going to see some unique lean mass preserving agents within these medications as well. So, just super interesting. In terms of fitness professionals, you have the opportunity to support clients using these medications. Whether you're working directly with clients or just kind of being a participant in society, you will interact at some point with people using these medications. The use is very prevalent. It's increasing. Just recently, I think like last week, there's an announcement about trying to bring down the prices because that has been an issue. Is just the cost of these medications. We know exercise and nutrition still matter a ton. Again, I think there's some freedom that comes to the fitness professional working with these clients because you can focus on some non-weight loss benefits. They're going to be doing something that'll be very effective on the energy intake side, so you can focus on the many beneficial effects of exercise beyond that. So improving function, for example, and we know exercise absolutely can do that. Similarly, on the nutrition, it's an interesting area because you're wanting to ensure that they're having adequate nutrition on the micronutrients, macronutrients. This is a good opportunity for dietitians and other nutrition professionals to tailor the diet and be sure that we're getting all the supportive nutrients we need for adaptations to exercise and so on within the context of a diet that has fewer calories, maybe even targeted supplementation here and so on. So big picture, I think this is super interesting. I think ultimately, I think it's helping people, which is great. But I think it also presents some interesting opportunities for fitness professionals. And if you want to be well-rounded, just some awareness of this area could help, set you apart. If you're entrepreneurial and you're wanting to start a business, you could even think about like focusing in this area. And saying like, okay, this would be a great client population, probably very motivated client population to draw from. So that is the end of my rambling there, but I'd be more than happy to entertain any questions if you have them.
Thank you, Grant. Let's give him a round of applause.
Thanks.
Grant, that was great. Thank you so much for all that background and kind of a research-based perspective on it. We'll probably have a bunch of questions from the class. I'm going to start us off with a little question, well, a couple of questions. The dosing strategy is in those papers is 1 time per week, but this current state looks like I'm hearing a lot about micro dosing. What do you know about micro dosing, and is that the way it's going to move to limit side effects?
Yeah, so I do not have a evidence-based answer for it because it has not really been studied in detail. I'd say this is in the realm where there are some practitioners who are experimenting a lot with that. There are some people who are reporting good effects with that. There are even some clinicians who think that maybe that microdosing these at some point in the future would be almost like a preventative strategy for weight gain and even cardiometabolic health. Because again, these were approved first for like diabetes treatment because of their like substantial blood sugar regulation benefit. So all that to say, I can't say like, oh yeah, if you instead of weekly, like here's a microdosing strategy or here's like a preventative micro dose you would want to use versus like a therapeutic dose. But yeah, I think that that is an emerging area. I'm curious to see at what point we have like legitimate high quality trials in that area. Right now, it seems largely anecdotal. The philosophy of Vineyard, for example, is that that's not currently something they're doing, but it's on the radar and not something that's written off as quackery because it would be nice to see, okay, how low of a dose can you go that'd be beneficial, even if it's more frequent. I will say though that for both the medications, there is a titration period. So you don't start someone out at the maximum dose. They do start at a low dose and they're gradually worked up. And typically you clinically, and I'm not the one doing it, I'm not a physician, but typically they would, if you're having success at a lower dose, stay there and it might be like at a plateau, then you work it up. But there are some individuals who go up, maybe too high and they have to come down. And even sometimes where you see better weight loss, not at the highest dose. So there is some individual tailoring on the titration that takes place. And if you want a concrete example of that, in our case series, we described this about how some people titrated up and then had to titrate down. Then they went to maintenance. Some even switched between medications and retitrated. So, point being, it can look very standard, but there is some individualization on the dosing. And I do think microdosing is an area that will be hot. As of now, I wouldn't like fully recommend it just because we don't have great data on it. But yeah, it may be promising in the future.
Great, thanks for that. I'm curious as on your case studies. Do you know about how many calories those people were eating on those?
Yeah, like, I should know off the top of my head, but it's been a few months, so I could pull it up. Well, I could pull it up over here.
Well, we can look through it, but I'm just curious because if it's really slashed, oh, did you go away? Oh,
Oh, am I not there anymore?
you're back. Uh,
Okay.
because I'm wondering if that's like really driving it, and then you're trying to have someone eat this higher amount of protein, and then they're already full from the medicine, and then they're trying to eat more satiating protein. Like, how
Yeah.
hard in practice? Because I know you have dietitians on staff, like for them to feed these people enough protein specifically, but food in general.
Yeah, it's a fantastic question, and it definitely, yeah. So I'll answer the first part. So patient by patient, the first one, the typical energy intake was 1,600 to 1,800 calories a day for the first female participant. The second, it was comparable, I believe. The males I know is higher. His was in the low 2000s. His average was 2,400 calories a day. So it was a larger male. That was case three, was 2,400 calories a day. So yeah, in the ranging of 1,600 to 2,400 calories a day. So it might be something again that it might be a target that you would come to just from lifestyle, but just I think being able to actually adhere to it. But what you mentioned is totally true. Like if you went ultra heavy on the protein in light of suppressed appetite, I think there have been some patients who have struggled with that and where the dietitians have had to work with them saying like, okay, you can't suppress your appetite on suppressed appetite too much. Like there's probably a sweet spot where you're having enough protein to help with lean mass preservation, support exercise adaptations, but not suppressing your appetite too much. I think the fiber management is important there too. So yeah, I think it's a really important question and probably one that, down to just like you would with other lifestyle counseling, down to the individual client and working with a nutrition professional, hopefully can find that optimal balance for them.
Yeah, that's great, man. I'll have to pick your brain. I'm gonna have the students ask some questions, but we're gonna submit a PO1 in January, which is 5 RO1s on GLPs. So
Oh
it'll
wow.
quite a bit of data if we were successful with those coming out
Yeah,
in
that's amazing.
the next couple of years. So, but anyway, let's go to the students and I'll come back.
Okay, sounds good.
Hello. So some of the side effects were like nausea, vomiting, and diarrhea. Do you think that having these side effects every day can cause dehydration, and how can they reverse that dehydration during the day?
Yeah, that's a great question. What I thought you were going to ask, which I'll also answer, is there are some people who have said that the GI side effects are why they have this effect. They're like, oh, if someone feels nauseous every day, they won't eat, and that's why they work. Which in individual cases, like you could probably find some case where that's true, but they've done good analyses teasing this out and showing that even in the absence of GI side effects, you see the same energy intake reduction and whatnot. In terms of the question of hydration, yeah, that is definitely a concern. And as you all likely know, it's not just the fluids we drink, especially if you're eating like a relatively nutrient dense diet, maybe a closer to whole foods, less processed diet. You're getting a meaningful amount of water from your food too. So if you're dramatically decreasing food intake, maybe if you have less appetite, you could potentially be drinking less as well. So I don't have like hard data on the prevalence of like actual dehydration, but I do know it's a common concern and that like electrolyte supplementation in this group is fairly common to help on the hydration and again micronutrient side. Even something as simple as sodium that typically, in the U.S. most people are not even close to having too low of sodium intake. But if someone is pairing this lower energy intake with less processed foods and so on, we could be at a situation where they're actually not achieving like ideal intakes of electrolytes for hydration and just general physiological function. So again, yes, that is excuse me, a concern. Something the dietitians, at least at Vineyard, are very aware of and work through with clients. But I don't have hard data on like the prevalence of dehydration as a concrete side effect, though that may have been studied. I just don't recall that.
I have another question
Yeah.
is GLP-1s decrease appetite and make you feel full and delete your thought of food. How do you think like after patients stop taking GLP-1s and they've lost all that weight, that bad weight, how can they maintain self-control after like stop taking the medication? Do you think that they
Yeah, I'm really glad you asked that because I actually should have mentioned this. There are different views on this. These are viewed as medications you would take chronically. So if you think, so the physician who runs Vineyard often likens it to blood pressure medication. If someone is taking blood pressure medication and they go from prehypertensive to normal blood pressure, typically they're not getting off it and saying like, okay, I got here with medication. Now I'm just going to try to maintain it lifestyle. It's more of like a chronic medication they use to maintain blood pressure at that level. So there's a large contingent, and this is kind of how they're designed that would view this as a chronic a medication you continue to take. Now, the maintenance dosing may be different. You may work down to a lower dose, but then you'd be at maintenance dose. It's like, okay, this is maintaining my appetite, my energy intake at a level where I can maintain weight or this weight reduced state over time. With that said, there are some patients who want to get off the medications. Group level, we've seen, so like on those charts where we saw the weight loss, group level, we've seen if you take everyone off it like a trial, they will start to regain weight. But that is similar to what we see typically with weight loss from almost any means. At the group level, we see weight regain. So it's tricky. There are some individual patients who have done this. They have gotten to the weight reduced state with the medications, then they've gone to lifestyle, and they've helped establish those lifestyles while having kind of like the encouragement, the success of weight loss with the medication. Then they're able to get off and roughly maintain it. But again, at the group, say like population level, if we're averaging everyone, you would need to keep taking the medications at a maintenance dose in order to reap that full benefit. And I think there'd be many who unfortunately would regain the weight, the appetite would come back. We know that anyway, even from lifestyle in a weight reduced state, your hormones controlling hunger, for example, and satiety are modified in a way that make you want to eat more and essentially regain the weight. So it's a really good question. Again, to summarize, some people would stay on them forever at a maintenance dose. Some might be able to transition off, but they will have a harder battle than those who stay on a maintenance dose.
I have a question. So I'm really glad that you had your kind of case series because the muscle building, muscle loss concern was something I was already aware about. But do you know anything about performance in the gym? Like, are these people still getting stronger, especially with like older populations that have kind of a sarcopenic obesity where strength is a big concern? Does GLPs seem to have any sort of negative effect to strength adaptations?
Yeah, so that's a fantastic question. I We had self-reported performance data for these individuals, but their types of exercise participation and programming were so varied that I didn't put them in because it was not very standardized. Our other information we collected in a standardized, more objective way. Um, I'll give you the answer from patients we've seen, and I'll tell you about like actual research that's going on that will look at this more directly. From actual patients, we do not see any attenuation of the performance improvement. So it's very on par with what we'd expect with the type of exercise they're doing. So for example, many are doing a structured resistance training program, and we're seeing adaptations like you would expect to those programs. There's some hand grip data that just came out from a randomized trial that was supportive that did not show any detriment. there were some big flaws in the style of the study that I think it was essentially the participants practicing the hand grip test why they get stronger. So I'm not super convinced by that. With that said, we're using hand grip like in our free living study, so it's possible we subject to that same issue. But there are better studies. One's called the T-Rex trial, so tirzepatide and resistance exercise, that's going to come out where it will answer it more what we would want to see as nutrition exercise professionals. So like a standardized, controlled, supervised resistance training program, a group on placebo, a group on the GLP-1, looking at their adaptations. So those trials are currently being conducted that will answer your question better. In terms of the sarcopenic obesity and aging concern, it's super important. Up to now, from the body comp data, particularly tirzepatide, and kind of the totality of what we know, I think there would be pros and cons there. I don't think there is strong evidence yet for a unique detrimental effect on skeletal muscle. I think everything is driven by the weight loss, at least with tirzepatide. But even with semaglutide, we've seen like when people exercise, just from the preliminary findings, favorable results. So I would, of course, be more cautious to do that. There'd probably be some risk benefit there of like, what is the bigger concern here? Is it like the aging functional sarcopenia realm, or is it more like the cardiometabolic realm, and they do have a lot of excess weight? I think probably this will be studied in the future. And in fact, I'm trying to remember the details. I was at Obesity Week this last week, and there was a presentation from Asia that was looking at individuals with lower BMI but high body fat, so kind of in the sarcopenic obesity realm, that they use these medications for. And I don't think they had a muscle performance component, but on the body composition side, it was favorable. So all that to say, I think we need formal trials in that area, but at this point, it'd probably be a case by case basis, the clinician evaluating like what is the greater concern here on the sarcopenic frailty function side versus this. But as we know, again, as exercise professionals, exercise helps everything on the function side. So like I would not, for example, if my aged grandparent was going on the medications, I would not be scared of that inherently. I would say like you, just like I would anyways, you need to be on, scaled to your ability, a structured exercise program to maintain function as you age.
Would there be any application to like cycling these in the bodybuilding space to help continue to burn fat mass while maintaining lean muscle mass?
I mean, yeah, I think so. Again, just from social media, I know there are people who are doing that already, and very thankful for them, because I mean, as anyone who's familiar with physique sports know, like the substantial appetite. You're getting down to just like incredibly low intakes, incredibly high hunger, lots of hunger related side effects. So yes, I'm confident they probably already are being used or abused, depending on how you want to look at it. I don't know if there'll be like a legitimate way to do it, but yeah, absolutely. I think anything that is effective, people in the physique community will try and use and self experiment and so on.
I have a question. When you talk about the chronic use of GLP-1s, how do you go about navigating someone who then becomes pregnant on GLP-1s?
Oh, that's a fantastic question. So I won't pretend to be an expert in that area. I think the current practice is to cycle off. Where some of the current research is right now is more in the breastfeeding realm. So it's known that like typically people will cycle off during pregnancy. And that is, I know on the psychological side, there are patients who struggle with that because, like obviously you should be gaining weight during pregnancy. Um, Especially maybe if you were in a weight reduced state to start. So I know that psychological aspect is hard. Where some of the questions are right now is, for example, like with breastfeeding, is it okay to be on the GLP-1 while breastfeeding? The current practice from physicians I talked to as recently as last week is to keep people off like during breastfeeding and then reintroduce after breastfeeding. So I don't know if there have been trials in it specifically or if it's more of a general precaution, but I think the general clinical practice at this point is to, when you're trying to become pregnant or when you know you're pregnant, to cycle off. I think there are a number of cases of people kind of accidentally becoming pregnant. I think it's related to the weight loss and changes in, fertility, maybe sex hormone concentrations and so on related to that. So I think there are some surprise pregnancies from individuals who maybe previously were having trouble getting pregnant, even if they weren't intentionally, even if they weren't aware of that, where there could be some surprise pregnancies in that realm. So that's kind of a side note, but that's a great question.
Oh, so I have a question about dosing. I know earlier you mentioned the half-life was about 1 to 2 minutes. Additionally, you also mentioned that a lot of times these individuals will have to take these medications chronically they can maintain the weight off. Do you see any like long-term studies where individuals maybe they've taken it for a year or two now, and then the receptors become desensitized, and you have to increase the doses and try trade up? Is that anything that you've seen in some of the data?
Yeah, so that's a great question. The titrating up is common, like at plateaus, and if you, my understanding is that it's fairly linear with energy intake suppression. So, like, say, just using arbitrary doses; these are not actual doses. At a dose of one, it's like, okay, you get some energy intake suppression. You reduce your calories to that point, you lose some weight, and then you plateau. Just the same way as if, say, you cut your calories by 200 calories a day, like a very modest deficit. Then titrating up to two, now you have greater suppression. You can get into a greater energy deficit, a little more weight loss. So, very similar to the way of if you were cutting calories just from, normal dietary measures. So yes is the answer. Where that maintenance dose is for people, some people titrate up to the recommended maximum, and they stay there. And even there are some people who will plateau. For others, they could be at like half the maximum dose and getting the rate of weight loss they want, and so on. Um, with that said, I have not seen any data on the receptors becoming desensitized to this over the course of well over a year. That's a really interesting question, but that, to my knowledge, I don't know. I don't know that it's actual receptor desensitization. I think it's more related to just what we would think of as a normal plateau in weight loss at a given energy intake level. I know it's not substantial. If it was a very substantial like down regulation of the receptors, I think we'd see more issues or less consistent results on the weight loss. So I don't know if it just happens to a small extent or if it doesn't happen, but I think it's primarily just driven by the energy intake plateaus at a given like appetite level, essentially.
All right, thank you for that answer. My question would be, you talked about working out 7 times a week. What about rest? What about recovery? Because we know that's important as well. So when people are like chronically taking GLP-1, is it something where you're like, okay, we're focusing on like keeping muscle mass, working out 7 times a week, and no recovery days in between?
Yeah. So for the 7 times a week, just to clarify, that was one case. So this was not prescribed. This was one patient who chose to do that, and it wasn't lifting 7 days a week. I think it was lifting 4 days a week. There was like cycling days in between. She tried to meet 10,000 steps just as kind of like a baseline active level. So yeah, that is beyond typically what we would prescribe as necessary for someone. This is just a patient who wanted to do that. She was very committed to like maximum results, minimum time. And she's the one I showed the DEXA scans of with 39 weeks, which is just wild. So yes, for the patients, this is something that's been interesting to me. Sometimes we can have the assumption that it's like, okay, the patient coming into a obesity treatment clinic, it's like, okay, maybe they're sedentary, they don't have experience with this. We have tons of patients who come in and have like a substantial athletic background and maybe are even currently very active, but just struggle with weight management. So it's really tailored to the individuals, similar to what if you were working with a client who's not on a GLP-1. If they were going from sedentary, you would not throw them into it's okay. You're going to do like hit today. You're going to do like an hour and a half lift tomorrow. You're going to whatever run a half marathon on Wednesday. Like of course, you work them into it. So it's really in clinical practice, certainly on like a case by case basis. We would normally recommend the rest days. There's some participant, and that some people in general, they're like, no, like no days off. I will not rest until I get hurt, and we know that's not optimal from the recovery standpoint. So yeah, again, just to clarify, that wasn't prescriptive in the trials being conducted in this area. It's more moderate. I think it's 3 days a week of like for the T-Rex trial, I believe. So yeah, great point. It's not what we prescribe, but as you know, individuals sometimes want to push themselves and not take a true rest day.
Hey, I have some different questions. Like, while a person has not started with GLP inhibitors, then when he's taking those medications, and if he stopped, then what are the differences in the food selection and the calories derived from the carbs, fats, and proteins? And also, are there any kind of mood changes because there are a lot of this medication has a lot of impact on brain. So are there any kind of mood changes involved in that?
Yeah, those are great questions. I'll say on the nutrition side, we are very much in the infancy of our understanding here. So from the weight data alone, and again, you all likely know this, but it's really hard to get accurate nutrient intake information in free living individuals. Really outside of a metabolic ward where you're providing all their food, weighing all the leftovers on their tray, all of that. So we have some data. I haven't from the data I have seen, I have not seen any dramatic shifts at the group level in macronutrient preferences. It's generally been fewer calories from everything, though that of course means for example, protein intake, like we talked about, there's probably a balance there. But in the absence of like intentionality related to protein, you could have protein intake go lower than would be supportive for maintenance of lean soft tissue or muscle mass. So I'd say that's an area of active research. We need better controlled trials. The best we have right now is kind of like dietary intake data, maybe ASA 24 for like a structured multi-pass interview, which is what we're using in our trial. But we need tighter data there. I think ultimately we would need like metabolic ward, very controlled data to get into the nuance of the food preferences. Even if we see group level effect, I would expect it not to be large. I do think that would be substantial at the individual patient level. We have patients who it's like they're on these medications and they do not crave sweets at all. Like it's just not even there for them, and others who don't experience that. So I think it is very individual to the patient on some of those like food selection factors that might influence macronutrients. And then the second question, side effects. The mood related side effects I have not seen on any of the lists of more prevalent side effects. It's usually always on the GI route. In the GI realm, except for like the fatigue, which I wouldn't say is like mood per se, but you know, if you feel fatigued, you may be, I don't know, moody or more irritable. So I haven't seen those listed. The areas of the brain impacted would not be ones that are traditionally like directly associated with mood, to my knowledge. So it's a good question. And again, I'm sure there are plenty of individual people who are whatever, maybe they're grumpier on it because they're, eating less, or maybe they're happier on it because they're whatever, they're losing weight and they're that's a big achievement after not seeing success there. All that to say, it is not one of the more common side effects. I'm not saying it's impossible, but it's not one that's typically stands out in the trials.
Dr. Grant Tinsley, thank you for your time. Let's give him another round of applause.
Yeah, thank you very much.
Hey, man, I really appreciate it. Thank you for your time and expertise, and I'll be reaching out to you. Thanks, man.
That was great. My pleasure. Take care.
Bye.